is I put down what I thought was a fair but perhaps I might think a challenging compare and contrast statement about insourcing and outsourcing, because of course insourcing could just reflect all the people you're happy to work with and want to work with, and outsourcing could include all the people who are quite difficult to do. So I'm a CCIO who's come into this job having been a clinician who worked with data. I'm an nephrologist in the other half of my week. And so I've approached it from the clinical process and a data perspective, rather than having any huge capabilities around making clinical systems or tying them together. So I come from the usability of making things work for us in terms of delivering patient care rather than a more technical standpoint. So outsourcing to me could reflect all of the technical people who I sit shoulder to shoulder with and work. But let's see what if this chimes with other people. So if we were going to insource something, we'd have to start off by defining what the problem is, and designing a product. We'd need to assemble a technical team with the skills to try and do that, and we go through a quite interesting and hopefully iterative process, of trying and testing the product. We'd be having to set some standards, or probably, if we were more mature about it, adopt some standards that are already in place and that are relevant to all the other environments that we're hoping to interact with. And we try and set a time scale. And we try and set a realistic time scale, but of course we fail because we always think things can go quicker and with more smoothness than we can do. We get to the point where we have a product, and then we would assemble the delivery team, try to keep the expectations of our colleagues in the clinical space down, recognizing that actually once they get something, they'll almost certainly find it more difficult to use than they thought, so they'll be grateful that we're not asking them to do everything all at once. We'll find lots of unknowns that happen through that process, but hopefully we'll get to a point where we can deliver and deploy, and if all goes well and we find that people will use it, we can plan the service transition and hopefully create a BAU function around that and remain in control. And I think this process, although there's lots of things that we find hard to control, does at least allow us to have some internal control. When we're outsourcing, it's a somewhat different thing. So we're much more expecting to be given something, and then we'll get what we're given. But we expect it to be tried and tested, perhaps in theory more than in practice sometimes. We may or may not have any control over the standards, but more often we'll have the standards imposed by what's present in that system. And then we'll be given the product, and with that product we'll be given a set of timescales that would seem hopefully relevant to us, but will be driven by experience of the provider more than our experience with that product, assuming it's something that we haven't had before. So we would probably receive a delivery team. We probably want to manage up the expectations of what we're going to get out of it at the end, rather than try and just go through a deployment at the most basic template. And we'd expect to be delivered and deployed to and have a smooth transition to service with a relatively locked down product. And so that's seems to be the two ballparks that we're working in there. Now that then means that we're probably receiving things in a different way. So most of the outsourced type systems are things where you'd identify a system, and through a traditional waterfall delivery, you pick a clinical process, you try to make it change a bit, you try to dial out the things that make it impossible for the new provider to actually work with you. So you try to stop being special and maybe become a bit more coherent with everyone else and a bit more generic. You'd attempt to make the clinical change, and you hope that, and through that process, and acquiring the system and having the resources to have the system in place, that the deployment would not be too painful. And hopefully, if we had to hold our breath through the deployment, we wouldn't have to hold the breath for too long so that we become stagnated or collapse. And some other things would happen. And hopefully, by the end of it, we'd have an end result that feels like what we started at the outset. So that will be fine if we know what we want, and what we want is what we need, and what we need is what we get. But if the alternative bit, which is I think more interesting from a clinical and from a service transformation perspective, is to do things in a much more agile and iterative approach. Now, that's not to say that you can't take external products and deploy them in an agile, iterative way, but it's much more under your own control if you try to do that yourself. So we would identify a problem rather than a system, try to work out what we want to do for that problem, and whether we want to do it all at once or in bits. We look then at the clinical process solution, and we try and iterate to a point where that clinical process is better, and we would go through a series of cycles where we would do a bit, deploy something, measure it, adjust the clinical process, then deploy a bit of technology that would help us to see whether that clinical process change would work, measure the response to that, adjust the technology, go through a number of cycles until we got it right. And we wouldn't know how long that would take, but we will be making progress and making clinical changes as we go on. And we may well find that we expected it to take 2 years, but at 6 months we've just about saturated everybody and got quite a big change through that. And by doing that, we would also learn how to manage our teams, manage our expectations, become better at adjusting the velocity of change, both from a technical and a clinical perspective, and our scope would evolve over a period of time. So a completely different set of disciplines. And those set of disciplines then apply differently depending on what systems you have. So I'll talk about the 4 major things that we've been doing at the moment. So where there is a something that you want, and it works, and it reports the information appropriately, and it gives you security, and you can have the right sort of support arrangements, it seems entirely appropriate to take a product and do it and use it properly. Now, hopefully it's been tested by other people. Hopefully you're not pushing the boundaries. A first of type implementation is always slightly more challenging than something that's where people have gone through the process before. A pharmacy system, though e-prescribing would seem to me a logical one, not to try and reinvent the system when there's plenty of systems that are there. So in that process, and this is the CSC or the ISOP MedChart system, we looked at all the prescribing systems that seemed to work with us. We took the one that looked best for us, and that was with wide clinical consultation. And we then gone through the process of deploying that. And this is a test view from the live system, which was deployed 2.5 weeks ago. And we found huge amounts of very interesting clinical things that needed to change, behaviours by nursing and medical staff on the wards and in theatres, about our organisational process that we knew were difficult, but we never had the tool with which to force the teams to change. And we've had to do very little with this product. There's some stuff that needs to come in as we move forward, and that's when we've got used to the process and used to the system, will be a comfortable point to be maybe deploying the first of a new set of features. But we've got a process that we know what it should look like, and we can deploy to that process. And when the stakes are pretty high around things like prescribing, you don't, I think, want to have too many unknowns that you have to deal with on day one. Insourcing gives us a whole lot of different things. So this is our core ICM clinical manager, which we've had for many years, and we could just deploy it, use it as an order comp system, and have the context driven from the patient manager and do nothing more about it. But we found it quite useful to think of it, and increasingly so, to think of it as part of the transformation process. So we have a system that's quite easy to do some small changes with, and it has a fairly low cost footprint to us, that we can then build a team for transformation around. This is an example of what we're trying to do with clinical handover. And the more time I spend on this, the more I realise that we probably should have done this 5 or 10 years ago rather than wait until now. But it's only now that we've got the clinical impetus to do it. And so the problem with handover is that we have people doing it multiple different ways, in multiple different settings, all doing it to a high standard, but the data all sits away from the clinical record. So if we were challenged by a legal case, or we were challenged to try and show that we collected that information we're using as part of the clinical record, we find it almost impossible. In some settings where there's an electronic document sitting somewhere on a secure server, and there's paper notes being written into on a fairly occasional basis, you'd probably say that the electronic document that we can't see, other than unless you're in that service, has more information than the stuff that's in the notes. So it's actually the medical record. So trying to drive that into a core system involves a team to identify, and including the people who are going to use it, so the junior doctors, to design the stuff that makes it work for them, work out what it is that we need to do to get them to work differently so that it is visible to everybody, that the nursing staff and the clinical and the medical staff will work together, that people can send information in who aren't present at the hospital night handover, so we can have a process where instead of turning up to handover to be told what's happening, you can attend handover and know what's happening, and then ask actually further information that helps you judge what to do and when to do it in the out-of-hours setting. The idea being that we will get the clinical process transformation at a relatively low cost, and then if we want to deploy a bigger system, a more refined system around that clinical change, we will have something that works at that stage. And this is where we would start to put this. So this is our in development e-noting solution, which is effectively a combination of a clinical portal and clinical content. So effectively, we've used our own thinking around best practice, but using standards to create a set of clinical capture tools and a clinical display function that should be intuitive to people. And if it's not intuitive, absolutely out of the box, it will become intuitive as it becomes the core way of doing things. So, and because we were designing this ourselves, but we wanted it to be fairly future-proofed and also to be consistent, we use standards. So this uses the common user interface header. It uses some standard approaches to accessing data and putting it through into a consistent view of patients, that allows you to then have a task-centric system that puts the patient care at the centre and everything else associates around the care of that patient. We can pull data up into reports, we can pull data up into views and flag patients developing higher risk scores, but that we can do it consistently across all the care settings. So this will become our core way of working, and everything else that we use will hang off that. This is the product, and I have to remember this. I wake up at night sometimes in a sweat thinking this. This is a clinical project, clinically driven, operationally supported project that is transforming our delivery of healthcare by creating electronic notes supported by the technology. So the technology is the last bit. It's the bit that gives us the final common glue. And by putting the clinical content system as within the portal, we can then access lots of other systems. So we can access Symphony Casualty System, we can access Rio and Mosaic, which are the community and the cancer systems. And so we can bring more of those systems into a single consistent view, based on what the clinical teams need to do, and giving the clinical teams the information that they need in a way that's very consistent. And finally, extending on from that, is actually starting to deal with the problems that come from outside of our borders. And this is where I think the insourcing approach allows us to have a flexible and empowered way of doing collaboration. So this is our other main development, which is in partnership with our colleagues at King's College and South London and Horsley, to join up our core systems to provide a single view of those core systems live in real time to clinicians who need to access information across the secondary care network. So the way we're organised is there's an awful lot of overlap with the way care is delivered in the inner part of South East London, both mental and physical health. And our academic health science centre's core remit is to try and improve the mental and physical health of patients in that, as well as supporting all the research and other aspects of the system. So this starts to give us the ability to to get a live view of the three systems consistently in one place based on the NHS number, and allows us to inform our clinical colleagues and have patients attending any of the three sites in outpatient or inpatient settings be having a clinician dealing with them, having a fuller set of their information. We're hoping this goes live very shortly. We're hoping that this will then start to become the front end for collaboration across primary and secondary care. It also, because we have the community system, provides to our colleagues in the other trusts who would otherwise have difficulty accessing the community system a consistent view across into that pathway. Now, this is the sort of thing that feels to me, and feels to us as a group, easier to do if we are doing that iteratively under our control, rather than having somebody coming in and grabbing hold of the systems for you and bringing them in under their terms. So I put the question at the end: what is preferable? And I'm not sure there is a preferable. I think one needs to make the right decision based on what you're trying to do. So if it's a standard tool, it works well, it needs little redesign, and actually there's a disincentive to configure it, the configuration can cause problems, then outsourcing seems logical. If it's non-standard, nothing quite fits, or needs to be a part of a wider process of service redesign, considering or at least partly doing it through insourcing, and that insourcing could just mean the transformation capability, seems to be a logical thing to do. There are some obviously some grey areas, but what is essential, what underpins all of this, is whichever relationships you have and whoever your suppliers are, internal or external. I think there are some advantages seeing internal colleagues as suppliers as much as there is for external colleagues. Making sure the relationships are good and profitable and you're working together is absolutely vital.